مجهود على أي زميل من الزملاء سواء داخل النيورو راديولوجي أو في أي قسم من أقسام الإشاعة. فأنا بشكرك على كمان تنظيم ومراجعة السيشنز بتاعة النيورو راديولوجي بتاعتنا في المؤتمر ده يا توجان، واستمتع أكيد بالتوك بتاعتك. اتفضلي.
بسم الله الرحمن الرحيم.
أحب أضيف كمان الريسيرش، يعني توجان من الناس المميزة جدا في الريسيرشز اللي بتعملها أو published internationally وحاجات very updated يعني.
شكرا دكتور.
فعلا وبتساعد كل الناس الحق.
ربنا يخليك.
اتفضلي.
بسم الله الرحمن الرحيم. أنا بس عايزة أقول البرزنتيشن بتاعتي هتمشي إزاي. هي دي كلها حالات أنا الحمد لله اشتغلتها، يمكن أنا حطاها في شكل أسئلة عشان الناس تفكر معايا، وأنا حاطة كمان الأسئلة اللي جت في دماغي وأنا بكتب الحالة. كان نفسي يبقى interactive session فعلا تجاوبوا معايا، لكن بس technical issues كده، فأنا هقرأ الأسئلة وحضراتكم هتفكروا معايا وأنا هقول على طول الإجابات عشان الوقت. CSF leak is due to an osteodural defect leading to abnormal communication between the subarachnoid space and adjacent paranasal sinuses or tympanomastoid cavity, presenting with rhinorrhea or otorrhea. The increased risk of life-threatening complication as meningitis emphasize the need for early diagnosis, accurate identification of the site of the leak, and timely intervention to avoid morbidity. Common causes of CSF leak include trauma, iatrogenic leak, skull-based tumors, congenital or developmental malformation, and spontaneous CSF leak. Imaging plays a significant role in the preoperative workup, identifying the site, size, and possible cause of the leak. I will start my interactive case, and please think with me. This is a 38-year-old female patient with left-sided rhinorrhea. Regarding the MRI and CT cysternography, check all that apply. Intrathecal contrast was injected in the CT and the MR cysternography. Active CSF leak is seen through the left cribriform plate of ethmoid. Active CSF leak is seen through the lateral sphenoid recess. No added value for the MRI in this case. No added value for the CT in this case. Think please. The correct answer is it is an active CSF leak seen through the lateral sphenoid recess. It is a case of lateral sphenoid recess meningoencephalocele. And here is the CT value with the superior evaluation for the skull-based defect, and it's confirmatory for the active site of the leak, noted by the contrast material within the sphenoid sinus. Arachnoid beads are usually associated with idiopathic intracranial hypertension, which is the underlying cause in this patient. And here is the added value of the MRI, which obviously shows the herniated meninges and the brain tissue, so the diagnosis is meningoencephalocele. Sphenoidal encephalocele usually associated with lateral pneumatization of sphenoid sinus into the greater wing of sphenoid. The clinical presentation varies from rhinorrhea, meningitis, epilepsy, or symptoms of intracranial hypertension. In the same patient with left-sided rhinorrhea, what is the cause of bilateral active leak as seen in the CT cysternography? Check all that apply. It is a bilateral disease with missed contralateral leak. The history may be misleading or inaccurate. It is a wrong technique. It is a paradoxical CSF leak. No difference between the early and late cysternography. Think with me. The correct answers are maybe history is misleading or inaccurate, and please recheck always the history. But actually in this case it is a paradoxical CSF leak. Paradoxical rhinorrhea is rhinorrhea from nostril contralateral to the site of the CSF leakage. It could be seen when the fluid leak traveled down to the nasopharynx, as in the delayed images of our patient. Paradoxical rhinorrhea can also occur with fracture of the midline structures in the crista galli and the nasal septum, as in this 70-year male patient with history of polytrauma. He has multiple maxillofacial and skull base fractures. He has a fracture in the planum ethmoidal region and fractures in the nasal septum. CT cysternography confirms active leak through the planum ethmoidal and the contrast crossing the midline through the fractured nasal septum to the contralateral nostril. My next case is a 7-year-old female patient with road traffic accident and CSF autourea. After reviewing the MRI images, the main abnormality or abnormalities are: it is a post-traumatic subgaleal hematoma, sizable subdural hematoma of different ages, no CSF leak, however post-traumatic hemotympanum is present, 2 different but related pathologies are seen. This lesion may resolve spontaneously. Think, please. The correct answer: there are 2 different but related pathologies, the arachnoid cyst and traumatic head injury, and this lesion may resolve spontaneously. It is a case of ruptured arachnoid cyst, intracystic hemorrhage, subgaleal and skull base CSF leak. 3 hypotheses are considered as causes for arachnoid cyst expansion: the valve mechanism, which is the presence of one-way valve through which CSF can enter from the subarachnoid space into the cyst during the systole; the oncotic pressure, which is the difference in the osmotic gradient between the CSF and the arachnoid cyst fluid; and the active pump, which is secretion of CSF within the arachnoid cyst. Risk factors for arachnoid cyst rupture are larger cyst, head injury, middle cranial fossa location. Children, adolescent, and young adults are at greatest risk of arachnoid cyst associated hemorrhage. Ruptured arachnoid cyst can resolve spontaneously. For that reason, our patient received conservative treatment and she is doing well. My next case is a 42-year-old female patient with left-sided rhinorrhea. After reviewing the CT and CT cysternography, which is or are the incorrect statement, check all that apply. CT fails to ascertain concomitant dural defect in a patient with bony defect. CT fails to distinguish between dehiscent and the thin non-dehiscent bone, and fail to distinguish between mucus secretion from the CSF collection. CT cysternography has low sensitivity in patients with inactive or intermittent leaks. CT cysternography may be negative in active leak due to obscuration of small defect and non-leakage of high viscosity contrast. In this particular case, CT and cysternography are diagnostic and no need for further radiological evaluation. Please think with me. The incorrect statement is in this particular case, CT and cysternography are enough for diagnosis. Here is active CSF leak through the dehiscent cribriform plate of ethmoid. But there is cystic posterior fossa abnormality and the herniated cerebellar tonsils needs further evaluation. MRI was done and showed posterior midline cystic lesion compressing the fourth ventricle without communication with the ventricle, ruling out Dandy-Walker malformation. Thinking the primary cause of the CSF rhinorrhea is hydrocephalus due to posterior fossa arachnoid cyst, our patient underwent ventriculoperitoneal shunting and her CSF rhinorrhea subsides completely. Posterior fossa arachnoid cyst presenting with CSF rhinorrhea without any symptoms of posterior fossa lesion as ataxia, dizziness, tinnitus, or hearing loss actually is quite rare. My next case is a 29-year-old female patient with previous endoscopic repair for CSF rhinorrhea, presenting with recurrent nasal discharge. After reviewing the CT study, check all that apply. The blue arrow refers to the osteodural defect treated with mucosal or facial overlay graft. MR cysternography is recommended for evaluation of this patient and is considered positive only with the herniation of meninges and cerebral parenchyma. Red arrows refer to the elevated intracranial tension secondary to the closure of the skull base defect and stoppage of the CSF leakage to the nasal cavity. It is a case of failed surgical repair, and CT cysternography will be confirmatory. It is a case of Chiari malformation and not related to the patient's rhinorrhea. Thank you, please. The correct answer, it is a case of failed surgical repair, and CT cysternography actually is confirmatory. As we see here, there is contrast leak through the defect to the nasal cavity and the ethmoid air cells. But the supratentorial hydrocephalus, herniated cerebellar tonsils, and abnormal dictal plate contour mandate MR evaluation. Here is the MRI images which revealed untreated dictal plate glioma and obstructive hydrocephalus that leads to failed endoscopic sinus repair of the CSF leak in this patient. The treatment of hydrocephalus or a tumor removal take priority over any attempt to close the fistula as initial operation. Many times, treating the cause responsible for the raised intracranial pressure is enough to stop the leak. I have here two different patients with different management and outcome. The patient with posterior fossa arachnoid cyst treated with VP shunt and the CSF leak subside completely. And the second, untreated dictal plate glioma and obstructive hydrocephalus that leads to failed endoscopic repair of the CSF leak. My next case is a 7-year-old child patient with recurrent attacks of meningitis, started after birth and last attack was 2 weeks ago. CT for the skull base was done. Searching for the cause of recurrent meningitis, check all that apply. It is a dehiscent tegment tympani with CSF autourea. There is a central skull base CSF leak through Sternberg's canal. A case of abnormal otic capsule. No skull base defect to explain the patient's complaint. It is an abnormal internal auditory canal. Think with me, please. The correct answer, it is abnormal otic capsule and abnormal internal auditory canal in a missed case of incomplete partition type 1 anomaly. IB1 is commonly associated with recurrent meningitis due to abnormal otic capsule that is involved in the formation of the stapes foot plate and the annular ligaments, resulting in congenital fistula. Defective lamina cerebrosa and wide communication with internal auditory canal is another factor. This is a companion case of a 15-year-old male patient referred for MR cysternography, and the medical report sent by the clinician is shown here. He told us past history of head trauma long time ago, recurrent bacterial meningitis, and much brain imaging. He asked for MR cysternography. The cysternography was done, but there is no CSF leak shown in the shown images. But there is another clue. It is a case of congenital CSF fistula through a defect at the level of the stapes footplate, commonly associated with the IP1 anomaly detected in this case. Many challenging issues in this case: a misleading history of remote head trauma and multiple previous brain imaging, ignored hearing loss in the history, considering it a sequel of meningitis, the requested cysternography protocol rather than a dedicated cochlear implant protocol. Meningitis and hearing loss are bidirectional causation. My next case is a 42-year-old female patient with left-sided clear rhinorrhea, post-COVID tinnitus, and moderate conductive hearing loss. She had CT skull base, which shows left-sided sinusitis and automastoiditis, but no definite bone defect. CT cysternography shows no active leak through the cribriform plate of ethmoid and anterior skull base, which is the most common site. But it shows active leak through the left nostril, contrast enhancement at the left Eustachian tube, and contrast enhancement at the middle ear cavity and the mastoid air cells. It is a case of CSF otorrhea presenting as rhinorrhea. Spontaneous CSF otorrhea can also be occurred in adult. As temporal bone develop, there may be congenital deficiency in the tegment which persists over the time. With every heartbeat, there is thrust of the brain on these weak areas. The pressure keeps on building over the years, leading to remodeling of the weak bones and finally presenting as cephalocele or CSF leak into the mastoid air cells. In such a situation, as the tympanic membrane is intact, the patient usually presenting with CSF rhinorrhea. And the take-home message: when we get normal CT of the paranasal sinus, a high-resolution CT temporal bone is required to look for a defect in the tegment bone with or without cephalocele. This is my last case, a 38-year-old female patient. Male patient with history of previously operated intraventricular space occupying lesion 4 years ago, presenting with recent left-sided weakness and lack of concentration. After reviewing the CT brain and skull base, check all that apply. It is a case of tension pneumocephalus. It is a sinking flap syndrome. It is a case of a paradoxical brain herniation. The brain parenchyma is herniated from craniotomy defect. The offending skull base defect is seen. Please think with me. The correct answers are: it is a sinking flap syndrome. CT scan revealed a large craniotomy with concavity of the overlying skin scalp. And the offending skull base defect is seen at the planum sphenoidal region. Sinking skin flap syndrome are a rare complication of craniotomy. It is a medical emergency that rarely complicates large craniotomy. It results from intracerebral hypotension and often triggered by acute imbalance caused by the CSF drainage or lumbar puncture. In the same patient, the clinician thought air entering a CSF leaks out and the CT cysternography was done. Please check all that apply. CSF leak is obvious through the skull base defect. It is a ball valve osteodural defect causing pneumocephalus with no CSF leak. It is a case of excessive CSF loss. A vacuum is created trapping air inside the cranium. CT cysternography is not sensitive and additional imaging modalities are needed to explore the site of the leak. Using the same modality but investigating the whole neural axis is needed to explore the site of the leak. Please think with me. The correct answer: it is a ball valve osteodural defect. There is excessive CSF leak and vacuum inside the brain, and using the same modality but investigating the whole neural axis is needed to explore the site of the leak. Here is the CT myelography for the same patient. Check all that apply. It is a case of CSF leak through an occult spinal dural tear. It is a case of CSF venous fistula, a case of idiopathic spinal cord herniation, a case of spinal arachnoid cyst filled with the CSF, still no CSF along the neural axis. Think with me. Actually, it is a case of CSF leak through an occult spinal dural tear. And because of there is enhancement in the epidural vein, we think there is associated CSF venous fistula. It is a tandem CSF leak involving a spontaneous spinal leak and a simultaneous planum sphenoidal defect. The patient presented with pneumocephalus and sinking flap instead of CSF rhinorrhea. Essentially, cranial and spinal CSF leak are associated with opposite CSF fluid dynamics. Cranial CSF leaks usually associated with intracranial hypertension. In contrast, spinal CSF fistula are associated with spontaneous intracranial hypotension. And finally, the imaging approach, we start with beta-2 transferrin in the nasal discharge. If negative, so there is CSF leak is unlikely and no further imaging. If positive, we have two types, if active leak or inactive and intermittent leak. If it is active leak, we have two approaches. Either go directly to cysternography pre and post contrast to show the site of the bond defect and confirm the leak, or other approach, do CT for the paranasal and the skull base. If single osseous defect, so surgical repair. If multiple osseous defect, we return back to the cysternography to know which defect is the site of active leak. But if inactive or intermittent leak, we have to do CT to show the bond defect and MR cysternography to show the CSF leak. If from previous CT cysternography we suspect cephalocele, so we have to do MR cysternography to show the content of the sac. Finally, in this workshop, I discussed pathogenesis and the types of the CSF leaks, sphenoid sinus cephalocele, uncommon presentation of the arachnoid cyst, the hidden inner ear congenital or developmental CSF fistula, the intracranial hypotension and the spinal CSF leaks, the imaging approach for the questionable CSF leaks. Here is my references and thank you.